Good afternoon, everybody. I would like to thank Veena Madam for giving me the opportunity to present on true muscle transplantation, which we started doing 5-6 years back with good results, and we have done it for now not only for esotropia, but we have done it for exo and hypotropia also. I will show you some videos and pictures. So very large angle is typically characterized, very large angle is typically characterized by an angle more than 70 to 80 prism diopters, and we all know that a single eye surgery would not be sufficient to take care of such a large angle esotropia. We know that supramaximal recessions and resections may lead to either a restriction of ocular motility or may lead to changes in palpebral fissure size. We also have a muscle transplantation as a procedure, and we know that it would augment our surgical results. This is a presentation of esotropia patients of 50 patients, but I would be showing results of other large angles also. So this was this we have done over a period of 5-6 years, and all the patients we did it in exotropias also, but the small problem was that in exotropia the major advantage of muscle transplantation and esotropia is that the ocular motility is quite good even after the surgery, even when you have done such a large angle, and the palpebral fissure changes are not typically not as much as we would expect in such large angles. But in exotropia the restriction post surgery is definitely there, and so we don't do it very frequently in large angle exotropias. And we have done 2 patients of TRO patients, thyroid orbitopathy patients, who were treated for that, and they were in their recovery phase, but they had tight inferior rectus. So this was this is the typical muscle transplantation surgery which we do for large angle esotropia. So this is just a standard. So this is the pre-op photograph. This is the standard separation of medial rectus, and once we separate this, we use a 6-O-proline to tie the ends. So we have taken 6-O-proline. This is a non-absorbable suture. This we are making it ready to suture the stump of lateral rectus on this particular side of medial rectus. So next we would dissect the lateral rectus out, and we will separate the lateral rectus and put 2 pairs of 6-O vicryl, one on the desired amount of recession that we want, and another at the insertion. And once we cut it, we will suture the posterior side, the distal aspect of lateral rectus, as much as resection we want to do. In this particular case, we are doing around 8 or 9 millimeter of resection, and then we will remove this particular anterior part or anterior part, the stump we will remove, and we will suture it to the medial rectus where we have 6-O-proline already there. So this is the end-to-end anastomosis. So we will suture it with the medial rectus. This is 6-O-proline, the 2 pairs. So we will suture. So in the exotropia, we transplanted the stump of medial rectus, and in the hypotropia, we transplanted the stump of superior rectus because we did a resection of superior rectus, and we transplanted it or grafted it or sutured it to the inferior rectus. So this is the surgery, and then you can, once the stump is sutured on the muscle, then we have done adjustable also. We have done adjustable, semi-adjustable. We have displaced the muscle superiorly and inferiorly also. Once we have done this, then you can just do a standard recession. In this case, we are then recessing the medial rectus just as we would normally recess. Only the anterior part of the stump would be attached here. So that is the this is a standard cross-sword technique, And these are some of the patients we will see in the slides only. So yes, so this is one of the patients. This is the pre-op, the lower left photograph. This is immediate post-op, and you can see the ocular motility of right eye. You can see that adduction is quite good. Even after a month, there is not much of adduction restriction. I will show. This is another patient and another patient. This is I'll just reduce the voice. Yeah, this is a pre-op. Yeah, so this is a pre-op patient. This is a 70-year-old gentleman. You can see that so FDT is very tight. FDT is positive in this particular patient. And so what we planned to do was we planned to do a superior rectus resection, and then we planned to take that particular stump and put it at the inferior rectus, because normally these patients are, once you do an inferior rectus recession, we have seen that the ocular motility is restricted inferiorly severely. So we thought that it would be a good idea to do to try a transplant surgery in the, this is the MRI of the patient, and then I will just show you so this is a standard surgery, and I'll just show you the post-op mode. So this is in the primary, this is exactly after 1 day after the surgery, and ocular motility elevation is slightly better, but see the inferior movement is quite better. You know, you don't get this much, even this much motility in normal if you do just inferior rectus recession. And see, we have done superior rectus resection also, so that also would restrict the inferior movement of the globe. But he has got good motility in the inferior gaze despite doing such a large recession. And this is the same patient. So the point is that sometimes you are forced to do just a single eye, and when you just have a single eye to operate, this is a good option. These are some of the previous studies. Diamond et al. The first study was way back in 76, mainly in animals they had done. It is important to read this study because this tells us what happens to that particular stump. It gets necrosed and then gets transformed into a fibrous scar. So it is not a viable tissue. It does not remain viable. It is just a scar tissue. And so they did a study on animals and found what happened to that particular stump. And before us, Dr. Amitava from Aligarh had done 3 cases, and all his cases were in exotropia. He had not done it in esotropia, but he had published his study in JPOS in 2005. And so there were, when we published our findings, there was a couple of questions that why it is not as good as a large hangback or a hammy hangback recession. We could feel that this was mainly because the arc of contact or the insertion still remains anterior to the equator, and probably that is what contributes to the good ocular motility, which would not be there if we just do a hammy hangback recession. So another question which was posed was that we can very well do a small spacer graft. Spacer graft would not be very conducive when it comes to the palpebral conjunctiva. It would immediately get extruded. So we felt that this was a good option when it comes to very large angles, and it is very simple because it is very similar to what we already do. We are good at doing recessions and resections, just that we have to transplant the resected portion over the recessed muscle. So this is another patient who underwent left eye muscle transplantation. These are some of the papers. Thank you very much.